and welcome to NOAHE Rounds 9, Session 5. I'm Dr. Erin Kerwin. I'm a Managing Principal here at IHE, and I will be facilitating today's session. I'm also joined by my colleague, Dr. Leslie Cyril, who is a Managing Principal here at IHE as well, and Leslie will be monitoring the Q&A. So I'd like to begin with a land acknowledgement. In the spirit of reconciliation and gratitude, the Institute of Health Economics acknowledges that what we call Alberta is the traditional and ancestral territory of Treaty 6, 7, and 8 regions, and the Métis settlements and the 6 regions of the Métis Nation of Alberta, whose histories, languages, and cultures continue to influence and enrich our community. So today, our presenter is Dr. Deirdre DeJean. Dr. DeJean is a adjunct professor at the University of Ottawa and the lead of health technology assessment and deliberation at Canada's Drug Agency, or CDA-AMC. In this role, she advances best practices in health technology assessment and deliberative processes for the expert committees who are responsible for developing recommendations and guidance. She has extensive experience developing and applying research-based approaches for incorporating values in health policy and using ethics and qualitative evidence in health technology assessment and appraisal. Before joining Canada's Drug Agency, she was a research associate at the University of Ottawa's Centre for Health Law, Policy, and Ethics, and completed a postdoctoral fellowship in public and patient engagement at McMaster University. Her academic training spans undergraduate training in English literature at McGill, psychology at McMaster University, and she holds both an MSc and a PhD in health research methodology from McMaster University. This training has shaped her interdisciplinary perspective on complex issues in health policy. So today's presentation topic is developing and piloting a deliberative framework for health technology assessment at Canada's Drug Agency. So in health technology assessment, or HTA, considerable attention has been devoted to strengthening evidence appraisal, yet less guidance exists on how deliberation itself should be structured and communicated. So this presentation outlines the development and pilot application of a principle-informed deliberative framework at CDA-AMC. Designed for both use across both drug and non-drug expert committees, the framework organizes deliberation across 5 domains of value. It emphasizes transparency and consistency in how these domains inform recommendations. So before we begin, I'd like to go over a little bit of event housekeeping. First, participants will be muted throughout the webinar. Second, to submit any questions during the webinar, please use the Q&A function. And also please note that the Q&A function is different from the chat function, so please feel free to add your questions at any point during the talk, but ensure that you're using the Q&A function to do so. Finally, the Q&A answering your questions will be facilitated over the final 20 to 30 minutes of the webinar. So thank you again for joining us, and I will now hand over to Dr. DeJean.
Okay, thanks for that introduction, and thank you very much for having me. I'm really happy to be talking to you today about the development and piloting of a new deliberative framework at Canada's Drug Agency. And this work reflects a multi-year effort to strengthen how our committees deliberate. So I'm going to walk through the rationale for the update to our deliberative framework, how we developed the deliberative framework, what we learned from the pilot, and where we're headed next. I'm going to start by doing my own land acknowledgement and tell you that I'm speaking to you today from Ottawa, which is located on the traditional unceded territory of the Algonquin and Anishinaabe Nation. Canada's Drug Agency acknowledges that Indigenous peoples have been and continue to be excluded from and harmed by Canada's healthcare systems. And in the spirit of reconciliation, we are committed to addressing these inequities alongside Indigenous communities. So it was important for me to say this separately because I also want to say that we remained mindful of that commitment during the development of the deliberative framework that I'm going to be discussing today. So first, I'll just start with some background and context to situate why we felt that this work was necessary. Deliberative processes have become an increasingly important area of interest in HTA internationally. So for a long time as HTA bodies, our attention has been focused on the collection and assessment of evidence and the standards for doing so. But more recently, we've shifted that lens of rigor and quality from the assessment phase of the HTA process to the appraisal phase, recognizing that how committees deliberate is as impactful as the evidence and the inputs that they considered. So we've seen more discussion in the literature and HTA around evidence-informed deliberative processes, and more attention has been paid to what good practices might look like. Just starting with some level-setting definitions, as we know, HTA is a multidisciplinary process that uses explicit methods to determine the value of a health technology at different points in its life cycle. And deliberation has recently been defined as the informed and critical examination of an issue and the weighing of arguments and evidence to guide a subsequent decision. So we can consider deliberation in HTA as involving weighing of multiple types of evidence and perspectives and applying that judgment to reach a recommendation, often in the face of uncertainty. A well-designed deliberative process allows individuals from various backgrounds to discuss the information, the uncertainties, and the considerations related to the technology under review. It also supports the acceptability of the recommendations by interested parties, and it strengthens the public confidence in the legitimacy of the process and in our resulting recommendations. So with those definitions in mind, I'm just going to show how we situate deliberation within the HTA process at CDA-AMC. So at a high level, the process can be thought of in 3 stages: input, throughput, and output. During the input stage, the review teams assess the available evidence and prepare reports that are shared with the committee members. And their review is also informed by input from interested parties. So this could include patients, clinicians, health system decision makers, and industry where relevant. These reviews are underpinned by our assessment methods, and that would include the recently released methods guide for HTA and the guidelines for the economic evaluation of health technologies in Canada. Deliberation itself happens in the throughput stage, where the committees weigh the evidence and the input to arrive at a recommendation. And their discussions are guided by a deliberative framework that helps to structure how the different considerations are examined. Finally, in the output stage, the committee's recommendation is communicated through a report that describes the rationale for the recommendation. And the recommendation is underpinned by a separate recommendation framework that outlines how the considerations should lead to a recommendation. At Canada's Drug Agency, recommendations are made by 4 expert committees with different mandates. So for the drug reviews, the Canadian Drug Expert Committee, or CDEC, reviews non-oncology drugs. The PCODER Expert Review Committee, or PERC, reviews oncology drugs. The Formulary Management Expert Committee reviews drugs across their life cycle. And the Health Technology and Systems Expert Committee reviews non-drug technologies and health systems. So these committees were established at different times and in different policy contexts. So maybe not surprisingly, they also developed different deliberative frameworks. These frameworks were similar, but they weren't entirely aligned in terms of the domains. So what we saw was not a lack of rigor, but a lack of alignment, particularly in how the deliberation was guided, how considerations were made explicit, and how that reasoning was ultimately communicated. So in response, we convened a cross-functional working group to look across committees and identify opportunities to strengthen deliberation. We were drawing on international guidance from an HTAI IS4 task force on good practices for deliberative processes. The working group included staff from various CDA-AMC teams, including health technologies and systems, pharmaceutical reviews, quantitative and qualitative methods, ethics, health economics, engagement, and our strategic partner for inclusion, diversity, equity, and accessibility. So ultimately, the working group was asked to explore whether the differences across the deliberative frameworks were justified, or if we could establish some overarching considerations through an aligned deliberative framework. And the objectives of that work were fairly straightforward. First, to articulate guiding principles for deliberation, then to develop an aligned deliberative framework that could work across the committees, and finally, to pilot and evaluate that framework in a real committee setting. So I'm going to briefly describe how the framework was developed. We started with the guiding principles for deliberative processes. So the HTI is for guidance for deliberative processes that I mentioned, emphasizes that deliberation should be grounded in, quote, principles that reflect the goals of the health system the HTA body serves. So with that in mind, we undertook a targeted review of published and gray literature to identify guiding principles relevant to the health policy context in Canada. So this included things like HTA guidance, such as the Statement of Principles and Ethical Foundations that underpins the work at INES in Quebec. It included national health policy documents, and it included the CDA-AMC strategic materials, for example, our strategic plan, which names the guiding principles for the organization. The goal here was to articulate a set of guiding principles that could ground the deliberation, and those principles ultimately became the foundation for the deliberative framework itself. With the guiding principles in place, the next step was to develop a framework that reflected both the established HTA guidance and frameworks and how our committees actually deliberate in practice. So we reviewed existing provincial, national, and international deliberative frameworks to compare and contrast what HTA bodies typically identify as relevant considerations. We also observed the CDA-AMC committee meetings to understand what considerations were already being raised explicitly by the committee members, and maybe more importantly, what was being discussed by the committee members implicitly in their deliberations. So the aim wasn't to invent something new, but to align what should be considered with what was already being considered and to make the deliberation more explicit and structured. So we started with some overarching categories drawn from those provincial, national, and international frameworks, and we broke into subgroups according to our subject matter expertise to discuss their relevance to our organization and to develop the domains of a proposed deliberative framework. Once we had a proposed deliberative framework, the next step was to refine both the guiding principles and the framework in consultation with a range of groups who are involved in or impacted by the HTA process. So first, we asked the internal CDA-AMC staff to provide feedback on how the framework would function within existing workflows and whether it resonated with the evidence reports that they felt they were preparing. We asked the expert committee members to focus on whether the framework was usable in deliberation according to them and whether the considerations were clear. We also consulted with health system decision makers who reviewed the framework for relevance and usefulness from their perspective as the end users of our recommendations. And probably most importantly, patient perspectives were incorporated through targeted roundtables with patient groups who had previously engaged with the organization on deliberative processes. So that was about a dozen of them. So this gave us the opportunity to gather feedback from them on the relevance and the clarity of the framework, to discuss the wording of the framework, and to answer any questions they may have had. And finally, the framework was included as part of a broader public consultation on proposed improvements to the drug reimbursement review processes, where any interested party was invited to provide written feedback. So feedback from all of those activities informed the next revisions of the framework, and it strengthened its relevance, its clarity, its usability, and its legitimacy. We piloted the deliberative framework in the Formulary Management Expert Committee, or FMEC. FMEC was launched in 2023, and as I mentioned, it has a focus on drugs across their life cycle. It also has an additional mandate to provide an opportunity to trial innovative HTA approaches before they're spread across the broader organization for adoption. The pilot was evaluated against 4 predefined criteria. So first, we looked at fidelity, or the extent to which the framework was applied as intended. We also looked at efficiency, and that included whether it supported focused discussion within the available time. The next thing we looked at was the relevance and comprehensiveness, and this was to assess whether it reflected the quality of deliberation that we were hoping for and was supported by the framework. And finally, we looked at the transparency of it, particularly how the reasoning behind the recommendations could be articulated to interested parties and whether this was supported by the framework. So this evaluation was conducted iteratively over 5 meetings from 2024 to 2025. And in each meeting, there are approximately 2 to 3 drugs that are deliberated on by the committee. Our evaluation included structured observation by staff using a predefined rubric. It included written surveys completed by the FMET committee members and verbal debriefs with those committee members and CDA AMC staff. So there are 2 parts to the results that I'm hoping to share. The first, of course, is what we developed, and the next would be what we learned from testing it. So I'll start with the first key output of this work, which was the guiding principles for deliberative processes. And as I mentioned earlier, we really wanted deliberation to be grounded in what matters most to health systems and to reflect the goals of health systems in Canada. Through our review and our consultation, we established 4 substantive principles as central to deliberation, and those were need, patient benefit, health system sustainability, and health equity. And I'll just explain our definitions of each of those. So need involves allocating healthcare resources according to the severity and urgency of health conditions, the capacity to benefit, and the acceptability, availability, and effectiveness of alternative health technologies. Valuing patient benefit means prioritizing health technologies that deliver net positive outcomes and improvements for individual or population health. Health system sustainability means meeting the health and healthcare needs of the population in a way that leads to optimal health in the present, without compromising the availability of resources to current or future generations. And finally, health equity involves distributing healthcare resources and systems to minimize unfair or avoidable disparities in health outcomes and experiences of care across the population. In addition to these substantive principles, the working group also recommended that the organization formally adopt the procedural principles for HTA deliberative processes that were established by the 2020 HTI Global Policy Forum. And these principles included transparency, inclusivity, and impartiality. So we can consider the substantive ones as what matters most to the health systems, and the procedural principles define how we're going to get there. So building on the principles, I'll now turn to the big reveal, which is the updated deliberative framework. And that's really how the principles are operationalized in our deliberation. So the framework brings together 5 domains at answering what is the value of this health technology. Within each domain, there's a set of considerations that guide the discussion. It starts with clinical value, and this asks, does the technology under review demonstrate acceptable clinical value versus relevant comparators in the setting in Canada? This domain focuses on the benefits and harms of the technology relative to relevant comparators and the importance of those effects to patients, and it takes into account the certainty of the clinical evidence. The next domain is unmet clinical need, which asks, is there significant clinical need arising from the condition despite available treatments? This domain captures the severity of the condition, the extent to which morbidity or mortality remain despite available treatments. It also provides important context for how evidence and uncertainty are interpreted by asking the committee to consider whether there are challenges with evidence generation, for example, because of the rarity of the condition or ethical issues in conducting research, such as vulnerable populations, which would include children, those experiencing mental illness, pregnant persons, or others. There's a separate domain called distinct social and ethical considerations, and we use the term distinct to acknowledge that HTA is inherently an ethical endeavor, and that these considerations exist throughout the domains and the deliberation. So here we're asking the committee to consider those factors that are not already considered in the other domains. This includes asking, is there significant non-clinical need arising from the condition despite available treatments? So this is intended to raise meaningful non-clinical factors, which are the social, psychological, and logistical factors that influence the appropriateness, the accessibility and the acceptability of a health technology beyond its direct clinical outcomes. So this could include patients' and caregivers' perspectives and needs related to the administration or care setting. For example, if the drug was an oral option versus an intravenous option that had to be administered elsewhere, whether it could be delivered at home or in hospital. It includes additional patient and caregiver values such as dignity, autonomy, and privacy. And it also includes the financial considerations such as out-of-pocket costs. And we do recognize that there is a bit of overlap between what we consider to be clinical need and non-clinical need, because addressing something, a technology that is able to be delivered at home may improve the adherence, for example, of a drug. So it would improve the adherence of the drug, which in turn would improve its effectiveness. But here we're really asking the committees to focus instead on, if we assume that the clinical effectiveness was the same, can we imagine that patients or caregivers would value the fact that something could be offered at home, irrespective of the differences in their clinical outcomes? This domain also asks whether there are any important measures that should be implemented to ensure that the use of the technology addresses relevant social and ethical implications. So these include the broader social and ethical considerations related to the design, evaluation, and implementation of health technologies, including the implications for relevant ethical principles or environmental impacts of the production, use, or disposal of the technology. The fourth domain is economic considerations, and it asks, are there economic considerations that are important to address when implementing the technology under review? This creates space for the committee to consider the economic evidence alongside its uncertainty. And I will say this was one of the domains that we really grappled with as a working group the most. I think originally it was actually named economic value. And because of the context at Canada's Drug Agency, the name was changed to economic considerations to better reflect how we actually consider economic considerations and evidence in our recommendations. And I'm going to speak to that in just a second. And finally, the fifth domain is impacts on health systems. And so here the committees are asked to consider whether there are impacts on health systems that are important to address when implementing the technology under review. This is meant to prompt the committees to consider feasibility of adoption, including the anticipated budget impact, system readiness, and potential effects on care delivery. So, importantly, patient perspectives are intentionally embedded across the domains rather than treated as a standalone category. And this was a shift from the original frameworks used by our committees, but it was really meant to reinforce that evidence and input from patients are not competing elements of the deliberation, but together they form an integral part of assessing each of those domains. In addition to patient perspectives crossing the domains, there are equity considerations throughout all of the domains to ground the framework in the guiding principle of health equity. So having walked through the domains themselves, I want to say just a little bit about how the deliberative framework is intended to function in practice. I think this is an area where we tend to get most of the questions. So a key design requirement from the outset was flexibility. The framework needed to work across different types of technologies, conditions, and review contexts. So that included drugs and non-drug technologies, rare or more common conditions, early or later in the life cycle reviews, and across the committees who, as I mentioned, have different mandates. So for that reason, the framework is qualitative by design. This is not a quantitative multi-criteria analysis. The domains are not weighted or scored, and their relative importance is not fixed in advance. Instead, the relative importance of each domain depends on the policy question, the decision context, and the nature of the available evidence. So this allows the deliberation to remain context sensitive while still being structured. The qualitative design also supports the interaction across the domains. For example, we recognize that considerations related to unmet clinical need may influence how committees interpret uncertainty in the clinical evidence, which informs their assessment of clinical value. Finally, the framework is not intended considerations that are listed within each domain that are meant to guide the committee and not limit them. And the committees do retain the discretion to raise additional considerations where relevant, ensuring that the framework remains responsive to evolving technologies, emerging evidence, and changing policy contexts. So what did we find? Overall, the pilot suggested that the deliberative framework functioned as intended and that it meaningfully influenced how deliberation was structured. With respect to fidelity, FMEC members generally move through the domains as anticipated, supported by a tool that guides the lead discussants. So our deliberations are structured such that for each review, there are 3 committee members who act as lead discussants, and they provide their assessment of the health technology according to the domains of the deliberative framework and their underlying reasoning before opening it up to the full committee for discussion. So this tool that we provided them, which is sort of mapped onto the deliberative framework, helped to ensure that the relevant considerations in the framework were raised systematically without constraining their discussion. In terms of efficiency, there was an initial learning curve, but once the committee members became more familiar with the framework and with its terminology, we found that it did support focused, well-structured discussion within the available time, rather than slowing down the deliberation. The framework also improved the relevance and the comprehensiveness of the deliberation. So it provided a consistent structure for weighing different types of evidence and input, and it helped the committees to articulate why certain considerations mattered in given contexts and why others may not. From a transparency standpoint, one key finding was the need for clearer alignment between the deliberation across the 5 domains of value and how the rationale for the recommendation was ultimately articulated. So as I mentioned earlier, the recommendation is guided by a separate recommendation framework. In the case of the drug reviews, the Canada's Drug Agency recommendations are anchored in clinical value, and the current recommendation framework stipulates that, for example, economic considerations and impacts on health systems are reviewed by the committees at each deliberation, but they do not factor into a recommendation not to reimburse a drug. So we developed a tool to support the committees, the drug committees in particular, in moving from those 5 domains of value to a recommendation that was consistent with that recommendation framework. This really highlighted that strengthening deliberation also requires corresponding changes to how the recommendations are documented and communicated, which informs subsequent work on our evolving recommendation reports. So let me get into that. Taken together, these findings shaped how we moved from piloting an FMEC to the implementation and the next phase of the work in trying to embed this deliberative framework across the organization. So following the successful pilot and informed by what we learned through that process, the deliberative framework was implemented across all expert committees at Canada's Drug Agency. Specifically, that meant that the framework was included in the 2025 revisions to our procedures for reimbursement reviews, and it became effective for new drug submissions that were targeting the October 2025 meetings for both CDEC and PERC. In addition to being implemented in the 3 drug committees, the framework also applies to the Health Technologies and Systems Expert Committee, which reviews the non-drug technologies and health systems interventions. So HTSEC doesn't use the same recommendation framework that the drug committees use, and their deliberation and guidance may emphasize different aspects of value, particularly factors related to implementation, system readiness, and service delivery. So as we've introduced it there, we continue to trial and refine supporting tools for that committee to ensure that the framework functions well for those types of reviews. That being said, we have heard a lot of positive feedback from the committee members. So implementing the deliberative framework also made clear that strengthening the deliberation wasn't enough, but we also had to look at the inputs and ensure that the inputs to deliberation were fit for purpose. In particular, over the last year, we looked closely at patient group input and how it supports the expert committee deliberation. The goal of this work was threefold. First, it was to reduce the effort and burden for patient groups, recognizing the amount of work they put into preparing these submissions. The second was to increase the clarity about how patient input is used during the deliberation, and relatedly, to better align the input with the kinds of considerations the committees are now being asked to discuss during the deliberation. So this work was about a year long and involved consulting with patient group representatives to redesign the template so that it aligned with the new deliberative framework and that it reflected both the information they wanted to share and their capacity to provide that information. And this new patient group input template was launched in January of this year. As I mentioned, in addition to patient perspectives, equity considerations are also embedded across the framework. And so this includes questions like, does the condition targeted by the technology under review disproportionately impact systemically marginalized or equity-deserving groups? Are these groups represented in the evidence? We ask, does the technology under review have the potential to address inequities in access to alternative treatments across different patient populations or different jurisdictions? We ask, are there any factors that need to be addressed to support the equitable implementation of the technology under review? So we've developed internal guidance and templates to ensure that these considerations are identified and included in the deliberation materials, the evidence reports that are provided to the CDA-AMC committees. That said, consistent with international HTA bodies, there is a lot of ongoing work at the organization to explore methods and tools for incorporating the relevant information needed for the committees to deliberate on those equity considerations. And also, just as the inputs to the deliberation had to evolve with the new deliberative framework, the outputs of that deliberation also had to evolve to better reflect the framework. So in particular, we looked at how recommendation reports communicate the reasoning behind the committee decisions and adjusted a section on the rationale for the recommendation. The reports were also updated to include a summary of the deliberation that's organized according to the domains of value in the deliberative framework. And they now also include more explicit discussion points indicating how patient and clinician group inputs were considered across all of the domains. So I've included here an example from a recently published report where you can see that there is a separate section for the domain of here distinct social and ethical considerations. And within that discussion, there is explicit reference to the patient and clinician group input, as well as the clinical expert input and how the committee considered that in assessing this domain. So together, these changes help to close the loop between deliberation and documentation, making committee reasoning more transparent and easier for decision makers and audiences to understand. So I'm going to close now and open it up for questions, but I want to briefly pull together what this work has accomplished, how it's being used, and what's coming next. So first, in terms of what this work did, it established a shared set of guiding principles for deliberation across CDA-AMC and introduced an aligned, adaptable deliberative framework. That alignment was important, not because the committees weren't already deliberating rigorously before, but because it gave us a common structure and a common language for making that reasoning more explicit, more transparent, and more consistent. In terms of how it's being used, the framework, as I said, is now embedded in committee deliberations across the organization, which includes the different contexts, drugs, non-drug technologies, and health systems. Importantly, it's not just the deliberation that's changed because of the deliberative framework. We've also worked to align the inputs with the deliberative framework, like the patient group submissions, and the outputs, like the recommendation reports. So the whole process better supports structured, high quality, and transparent deliberation. And finally, looking ahead, this is very intentionally not the end state. Deliberative processes evolve as evidence standards evolve, as technologies change, as expectations of transparency and accountability for our organization continue to grow. So the framework is really designed to support ongoing refinement, whether it's through the use in practice, through feedback from our committees or from our external partners, and through our continued methodological work. And our focus here really is on continuous improvement and strengthening the deliberation over time. So with that said, I am happy to take any questions that may have come in.
All right, thank you so much, Dr. DeJean. This is such impactful and important work, so thank you so much for sharing it with us. We'd now like to invite attendees to use the Q&A function in the software menu. We do see that some questions have already come through, so I'll read them out and then we'll give some time for a response. So first is from Alden Spackman. He says he was interested that it was decided to use that the framework would not use value weights. So could you talk more about some of the pros and cons of that decision?
Yeah, thanks for the question. This was something that has come up several times when the framework was being reviewed by external parties. There are some examples, even in the ones that we were reviewing and comparing and contrasting, where weights were used. Ultimately, part of the reasoning was that the organization has in the past tried to use a quantitative MCDA, and it just didn't work out that well. So what we found is that even when you are sort of deliberating on something that is quite quantified, they would still get to a point where there was more of a qualitative discussion for things that were on the border and that sort of thing. As I mentioned too, there is an interaction between the domains that we've established. So it would be sort of impossible for us to acknowledge that the social and ethical considerations impact the clinical value, that the unmet clinical need impacts the assessment of clinical value, and to keep that sort of weighting in mind. So it was really important that we stay qualitative for that reason. And it was just important to allow for that flexibility across the committee. So as I mentioned, there are different recommendation frameworks for the committees, and this allows us to have a sort of overarching framework that can be picked up by non-drug and health systems as well as the drug reviews, and they can apply their own sort of relative importance to the domains.
Great, thank you so much. The next question is from Rebecca Marsh. She says, thank you so much for this clear overview. It's very thoughtful and impressive work. Are there specific elements of the framework that help participants navigate higher uncertainty, such as with novel therapies for rare disease?
Yeah, so the domain on unmet clinical need was developed partly because it is one that is commonly used in HTA frameworks, and partly because in the recommendation framework for Canada's Drug Agency, there was already a specific stipulation around significant unmet clinical need. In the past, it had been applied specifically to drugs for rare diseases. And so that's where, as I said, we're looking at the severity of the condition. We're looking at whether the available treatments are safe and effective. And probably most importantly, we're looking at whether there are any challenges in generating the evidence that may suggest that the committee should allow for a greater tolerance for uncertainty. And so we've expanded that from its original focus, which was on drugs for rare diseases, to acknowledge that those challenges exist for other populations. As I mentioned, mental illness, pediatric HTA is another large one where we might expect that the committee should perhaps have more tolerance for uncertainty. So in terms of sort of offsetting the uncertainty in the assessment of clinical value, it really is that second domain on the unmet clinical need that focuses on the reasons that might be underlying that and allowing for greater tolerance.
Fantastic, thank you. Next question is from Leslie Sorrell. So she says, great overview, thank you so much. And can you speak to the decision to embed equity across all 5 domains, which I know you touched on already, but just expand more on why it was decided to do that rather than have it as a standalone domain and what trade-offs came with that choice?
Well, that's a really good question. I'll have to think a little bit about that one. I mean, I think it naturally came up that there are equity considerations throughout all of the domains. So for example, when you're looking at the clinical value, there is a question around who is represented in the clinical trials that you may be looking at. So part of it was just that it felt a little bit challenging to separate all of those elements from the conversation around clinical value or which other domain it might have. But you're right that there are some trade-offs. In particular, I mean, I think we often think about sort of the balance between efficiency and equity when we're thinking about our recommendations. And I find that with the equity considerations sort of distributed across the domains, it can be a little bit more challenging to be explicit about where equity is really driving that conversation. So this is something, again, hopefully the framework pushes the committee to be quite explicit about when equity is really driving them. But I think that is one of the trade-offs of not having it as a separate category and instead having it embedded, is that they really, really need to be transparent about which of the considerations under that domain are influencing their deliberation and their recommendation.
Great, thank you. Next, we have a question from Deborah Marshall. She says, thank you for this presentation and explaining the process so clearly. Would you please expand on the rationale for not using MCDA framework, which you mentioned explicitly? Also, were methods like stated preferences considered at any point in your discussions to be part of the process?
Yeah, so I think I touched on this one before. It was really historically our experiences in previous deliberations with frameworks that involved weighting. I think it just allows for more flexibility in the framework. We were aware of other committees that were using weighted ones. We also, in doing this work, spoke to the staff at some of those HTA bodies and heard some of the challenges around those sorts of more quantitative rubrics once they were actually put into place in the deliberation. So it was something that we considered, but just didn't think that it would be feasible with our committees. I'll also say that this deliberative framework was driven a lot by input from the committee members. And the committee members really prefer to keep things flexible rather than have a more rigid sort of algorithmic way of doing things. I think even if we had tried to implement that, they may have not responded well to it. So that was sort of the reason why. There wasn't really an underlying sort of methodological reason not to do it, because I can appreciate that there are some people who would argue that that would be a better strategy.
Great, thank you. We've got lots of questions left. So next one is from Manhung Wen. Can you say about how the framework could support the voice of patients or citizen members in the committees during discussion and deliberation?
Sure. So I guess I'll say too, I mentioned that there were lead discussants from the committee who sort of lead each review. And one of those lead discussants is always a patient representative from the committee. And that patient representative speaks for about 15 minutes at the beginning of each deliberation. And they sort of organize their comments now according to the deliberative framework. So one of the reasons why we wanted to evolve the current patient group input submission was to make it easier for the patient members to make the link from what they had heard from patient groups to what they were being asked to consider with the rest of the committee. I'll also mention too, as some of you may know, that there has been some evolving trialing with persons with lived experience who do attend some of our deliberations to speak about their experiences and to answer direct questions from the committee. And this is intended to complement the patient group submission. So really, it's just, we haven't yet been able to see the impact of the patient group template having changed, because this just happened in January and there is a long call for patient group input. But we are hoping that with those changes, it will become much, much clearer how the patient group input has been weighed across all of the domains and ultimately in the recommendation.
Thank you. So for my own understanding, I've only attended CDEC, and I did prior to all of these changes. So is this patient statement brand new across all the committees under this new framework, or had it been in place for some committees prior to that? Not the patient engagement, but like the patient participation in the actual deliberation.
Right. So the patient member presenting is consistent across all of the deliberations, that there's always 15 minutes where they start by explaining what they heard from the patient groups as well as the clinician group input. The participation of a person with lived experience is a relatively new addition. It was originally trialed like the deliberative framework in the drug reviews in FMEC, and then it also was subsequently introduced into CDEC and PERC. With the revisions to the 2025. It is currently for a subset of the reviews, so it's just for the ones that we would call our complex reviews, but there have been several of them, and the feedback from the committees and from those who participate has been quite positive.
Oh, that's super cool. Thank you. Next question is from Sandeep Chand. Although Quebec has its own HTA agency, NOAHE, were stakeholders from Quebec engaged in the framework development process given the province's societal perspective?
Yeah, and now I regret that I didn't mention that we did work quite closely with our colleagues at NOAHE who were at the same time as us reviewing their deliberative framework. And so there was this sort of exchange back and forth. I think, we're always mindful of alignment where possible with the NOAHE process. As was mentioned, of course, it's slightly different because it has that provincial focus versus our need to include a pan-Canadian perspective. But yes, we definitely were working with those colleagues to ensure that we were coming up with a process that was, fairly similar. And part of this was because we also know that patient groups submit input to both CDA-AMC and to NOAHE. And so, of course, asking similar questions and using similar frameworks makes it easier for them as well.
Great, thank you. I might piggyback off that question. Classic health economist question about the societal perspective. I know there's a lot of interest in HTA bodies in adopting more of a societal perspective or considering it in some of the frameworks. How do you see this fitting in with your new framework?
It's an interesting question that has come up a lot. So Canada's Drug Agency is at this time undertaking a trial of the societal perspective. So when there is a societal perspective as part of the submission, it is discussed under the domain of economic considerations. So there's an additional question that the committee is asked to reflect on about whether they felt that all of the appropriate costs were included. So there are separate questions when there is a societal perspective under the domain of economic considerations, but otherwise it doesn't change the interaction of the other domains that much.
Great. Okay, thank you. We've got a follow-up question from Sandeep Chand. Thank you for the insightful information. Could you also provide insights into how acceptable clinical value is defined or assessed, particularly in the context of HTA and reimbursement decisions?
It's a fantastic question. HTA is a sort of subjective endeavor, which is why we have the committees who are made up of different perspectives, ethicists, clinicians, et cetera. And so they do often grapple with the idea of what they're considering to be acceptable. And, there isn't as much guidance that we can provide to them because it is a somewhat subjective judgment that they're making. I will say, the wording of clinical value was also chosen explicitly versus other options such as, clinical effectiveness, clinical benefit, et cetera, because we were really trying to show that in order to demonstrate value, it's not just about whether the drug demonstrates clinical benefit. It's also really important for the committee to consider whether the appropriate comparators were used, whether the outcomes that were assessed are actually important to the patients, and then, of course, the certainty of the evidence. So that's sort of why it's considered value, because there are a number of different layers beyond just clinical benefit that go into determining whether something has acceptable clinical value. But I think our committees also grapple with the idea of a little bit more of a specific objective threshold for that, but that is just not the nature of deliberation.
Great, thank you. We've got a requisite AI question. So Tanya Iwashko says, I really appreciate the work involved in this framework. I am curious whether you have applied it to review of digital health technologies, particularly those that include AI.
So the first review that the HTSEC committee completed, at the time it was known as HTERP, the Health Technology Expert Review Panel. In September of 2024, they did a review on rapid AI for stroke detection. And in that deliberation, they did use the deliberative framework. They were also using a different assessment framework that considered broader considerations around AI, but they did apply the deliberative framework. And that report should be available on our website to give a sense of how the deliberation played out. with the new deliberative framework on an AI technology.
Great, thank you. A question from Manuela Young. So she asks, out of curiosity, which HTA agencies use MCDA multi-criteria decision analysis in their decision making?
So there are many. The one that I'm thinking where we had the most conversation would be British Columbia. They have one that had sort of a rubric that involves quantification, and so we had some conversations with them around that.
Thank you. So I guess my question is, when you developed this new framework, did you notice engagement changed across the committee members? There's always committee members who are perhaps more reluctant to speak up or kind of say less in the meetings. Did that change at all under the new framework?
I think probably one of the biggest changes was, even though I genuinely believe that all of these domains and all of the considerations were already being discussed, whether it's explicitly or implicitly by the committee members, there is a perception that this is now a sort of expanded view beyond the clinical and economic evidence. And so what we have seen is the committee members engaging, I would say, more in those social and ethical considerations. There has been for a number of years ethicists on both CDEC and PERC and on HTSEC who were contributing that. But now what we see with the deliberative framework is the expectation that all of the committee members would be contributing to those sorts of conversations. So I think what we're seeing is folks sort of stepping outside of their comfort zones, or maybe the hats that they might wear, whether it's economist or clinician, to really speak to all 5 of those domains.
Great, thank you. All right, well, I think our Q&A has slowed down, so I want to thank you once again for your presentation, and thanks to everyone online for attending. The next seminar will be presented by PhD candidate Megan Wiggins, Dr. Betsy Burgess, and myself, and is scheduled for May 20th. Also, a quick reminder that abstract submissions for Alberta Health Economic Study Group are currently open, and the deadline is May 31st. So please visit NOAHE.ca to register for any of our upcoming sessions, and while you're there, you can also subscribe to our mailing list to get updates on all NOAHE events and opportunities. So once again, thank you, Dr. DeJean, and thank you everyone for joining us today.